Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Today's podcast will focus on tardive dyskinesia, and I'm honored to be joined by Dr. Christoph Carell, Dr. Andrew Cutler, and Dr. Rakesh Jain. Dr. Carell, if you could take a moment to introduce yourself.
Thank you. Really happy to be here. My name is Christoph Carell. I'm both professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra Northwell in New York, USA. And I'm also professor and chair of the Department of Child and Adolescent Psychiatry at the Charité University in Berlin, Germany.
Thank you, Dr. Carell. Dr. Andrew Cutler.
Yes, I want to first say what a pleasure it is to be here with two such respected friends and colleagues. I am Clinical Associate Professor of Psychiatry at SUNY Upstate Medical University, and I'm the Chief Medical Officer of the Neuroscience Education Institute. And my interest in TD really comes from a long-standing work in the field. I was Medical Director of a community mental health center where I saw a lot of patients with severe mental illness and tardive dyskinesia, and experienced quite a bit of frustration before we really had any FDA-approved effective medications. And so it's exciting now since 2017 to have such medications available.
Thanks so much, Dr. Cutler. And Dr. Rakesh Jain.
Hello, everyone. My name is Rakesh Jain, as you heard, and I am a clinical professor of psychiatry at Texas Tech University School of Medicine, Permian Basin. And I also have a private practice of psychiatry here in Austin, Texas, and it's good to be with all of you.
Thank you so much to all three of you again for joining us today. This topic today is employing evidence-based management strategies for tardive dyskinesia. And some general questions that I had on the topic are, what are some of the most important evidence-based guidelines and management strategies for the prevention, the diagnosis, and the management of tardive dyskinesia? And what do you find are the biggest challenges in implementing these strategies with patients, and how do you, on a practical level, address some of these challenges?
Well, I think you have to understand where we used to be with tardive dyskinesia. And Dr. Jain, I think, summarized the three phases of our relationship with tardive dyskinesia beautifully, that we were afraid of it. Then we were ignoring it because why would I really be aggressively diagnosing something that I can't treat and I could potentially be sued for causing? And now I think we're learning to live with it and embrace it, that we have effective treatments. I think for a lot of clinicians, one problem is they may not have been well trained on how to recognize TD and how to differentiate it from other movement disorders. Unfortunately, people have not been well trained on the management of tardive dyskinesia, particularly with respect to pharmacotherapies, to medication managements. And I think people may be a little intimidated, thinking that, well, I have to do a formal rating scale such as the AIMS, the Abnormal Involuntary Movement Scale, and that's going to take time and it's difficult to administer. Well, really, the APA guidelines now recommend we screen for tardive dyskinesia at every encounter with every patient on an antipsychotic or a D2 blocking agent. Now, screen does not mean a full structured evaluation such as the AIMS. It simply means you look for it and you ask about it. Ask, have you noticed any abnormal movements? Has anybody commented or noticed? Is there anything that you're having trouble doing now that you didn't have trouble doing before? Of course, observe the patient carefully, the whole patient, and also make sure you have a good relationship with the rest of your team, with your staff, and ask them, because they often observe the patient, say, in the waiting room or in situations where the patient may be more relaxed and they may see the movements. We used to be taught, and our guidelines used to tell us, that if you suspect tardive dyskinesia, to do things that had to do with manipulation of the antipsychotic medication. So for instance, lower the dose or even stop the medication, or switch to a lower potency agent. In the early 2000s, I was medical director of a clozapine clinic, and many patients we were putting on clozapine with the hope that their tardive dyskinesia would get better. And to be honest, it was not universally effective, a strategy. I think one of the things for us to do, and another thing in the management, of course, is to minimize the use of anticholinergic medications, which don't effectively treat tardive dyskinesia, and in fact can make it worse. And I think that that's an educational effort that certainly the three of us has been very involved with, is how to handle that situation, but also then how to use the FDA-approved evidence-based treatments. We're fortunate to have two FDA-approved VMAT2 inhibitors available to us.
That's a very comprehensive look at some of the errors, if you will, in the field and how we might be able to improve it. Perhaps we should step back for a moment and take a measure of our enemy. There are about 800,000 Americans who are living with tardive dyskinesia. Only 15% have been diagnosed. And you know what? Only about 6% are receiving treatment, which translates into 19 out of 20 people who have tardive dyskinesia aren't being offered appropriate treatment. So there's absolutely no grounds for complacency in the field of psychiatry on this issue. So what do? Your question was about guidelines. Do we have them? We have several good guidelines. So certainly, but focusing on, let's say, the Canadian guidelines and the American guidelines, there's profound convergence between them. And let's just focus on the APA guidelines just for a moment. It mandates, in some ways, as Andy just said, to look for tardive dyskinesia, either informally or at appropriate intervals formally. Point number 2, it asks us to not limit ourselves just to evaluation of the patient's movements, but the evaluation of the patient, the human being, their functionality. And if TD is present and if functional impact is to be found, then we are enjoined to treat these patients. At the moment, there are challenges all the way from appreciation that tardive dyskinesia is common. Many clinicians think it happens only in community mental health centers when patients have schizophrenia, almost as if this is a disorder of homeless Black men. That's emphatically not true. There's not a segment of the American society left who could not be afflicted with tardive dyskinesia. I've seen it with my own eyes. At both ends of the age spectrum, race, gender disorders, it can afflict us human beings. Point number 2, I don't think I've ever seen tardive dyskinesia where there's not fear of the condition, either by the caregivers or by the patient. Psychoeducation is so important. One doesn't just make a diagnosis, write a prescription and assume your task is done. I would like to recommend to our colleagues, bring humanity to our game here. This isn't some puzzle to solve. This is a fellow human being who's frightened, who's scared, and has, on top of everything, another psychiatric disorder to deal with. Tardive is not just the only problem. And finally, what I would urge clinicians to do is to follow the guidelines on treatment. Dr. Cutler informed us that there are 2 approved FDA treatment options available, valbenazine and deutetrabenazine. The database on both of them is quite strong. They can be used along any of the antipsychotics or even without them if that's so necessary. Both of them now have good long-term data. And we should think about the long-term treatment of these patients with tardive dyskinesia. That is the call to duty for psychiatry, assuming you're going to continue being a psychiatrist or a mental health professional for the next several decades. Please be aware, tardive dyskinesia is going nowhere. As a result, we should really up our game in diagnosis and treatment of this condition.
Wow, that's great. Thank you very much to the two of you. I think you've outlined the main issues that we need to deal with, and I would put them into 4 buckets. One is psychoeducation, the next one is prevention, the third one is assessment and diagnosis, and then the 4th one is treatment. And Rakesh, you already mentioned that psychoeducation often falls short because we focus on efficacy. We don't want to scare patients who may have problems with adherence anyway. When they hear about that, they're out of the door. But we can face things much better when we can name them and when we can then know what the plan is once first symptoms occur, rather than not educating patients and families. They don't know what it is and they come too late. As Andy mentioned, early intervention may be particularly helpful here. The next one is prevention. Now, we've gotten better of not treating to the neuroleptic threshold as much, but I still see patients who are treated to EPS, to Parkinsonism, and then an anticholinergic is slammed on. Although there are no data to suggest that once you go beyond the neuroleptic threshold that you get any more efficacy. You just get more side effects, you get dysphoria, you get secondary negative and cognitive symptoms, and patients have reward problems and dislike us and our treatments. So don't go there. Find a treatment that can get the patient the efficacy without causing these postsynaptic dopamine blockade related side effects. And then assessment. I think, unfortunately, many people don't know how to do an AIMS, how to do it efficiently and quickly. It doesn't have to take 10 minutes. Once you know what you're doing, once the patient knows what you're asking them to do, you can do that in 2 to 3 minutes. And as Andy mentioned, even just going into the room, observing the patient, asking them whether other people have pointed out whether they have certain movements or problems with their fine motor skills that they didn't have before, can go a very long way. Even at the time of the pandemic, when telemedicine was on the forefront, we still were able to see the face where 80% of the movements might be. You can let them stick out the tongue and even put the fingers in front of the camera. So that assessment is crucial. Knowing the differential diagnosis, what are tics, what are myoclonic jerks, what is hypokinetic movement, and that would be the EPS. That's not dyskinesia. Dyskinesia is hypermotoric and it's also irregular. This tremor for Parkinsonian symptoms is regular. That is not tardive dyskinesia. So just these simple rules. And now we have even very good videos online that can teach clinicians who are interested in knowing about this. And then you've already mentioned it. The last one is treatment. We have treatments that are FDA approved. After 7 decades it took, after the discovery of TD, finally we have something, and it's not used. People don't diagnose TD, and when they have to diagnose, they don't use the VMAT2 inhibitors, tetrabenazine or valbenazine, which can be added without worsening of the underlying condition, without having necessarily to change the antipsychotic when it's foundational for our patients. So that is really something where we as a field, as Rakesh also said, have to stand up, add humanity, also look beyond the movement, see the urgency of the call, that this really means something for patients and the environment, that people are stigmatized, that they feel they can't speak as well anymore, they can't use their fingers, and they are not themselves as much. They are much less, and data suggests that likelihood of being hired for a job or being on a date, because we look at people's faces. We find when they're out of control of their movements that is a problem. And as we mentioned, even sleep can be impaired, and that's one of our vital signs. If you can't fall asleep because of your movements, that then has a profound effect on the next day functioning as well as also cognition. It means that although this looks, feels, and smells like neurology, it's not me. I'm talking about the brain when it comes to voices or mood or mania. No, it's us. We are partially or fully responsible for it in some cases. And even if you haven't started the medication, we should deal with the whole patient and help them deal with the symptoms, but also use the medication we have at our hands right now that can help patients to a very big degree.
I'd love to add something, if I could, to what Christoph is saying. The idea of differentiating drug-induced movement disorders, and you introduced the concept beautifully, I think, of the hyperkinetic versus hypokinetic. So Parkinsonism is by and large a hypokinetic movement, bradykinesia, muscle stiffness. The face does not move, they don't blink. However, there is one hyperkinetic movement that you mentioned, and I think this is where the confusion comes in, and that is the tremor, which is regular and rhythmic. Whereas those of tardive dyskinesia are in general hyperkinetic movements, and they can be anywhere in the body. And that's actually, guys, a point we didn't bring out so well before, which is I certainly was trained that this was predominantly orobuccolingual or facial dyskinesia, but it can affect any skeletal muscle, essentially any part of the body. And then I think traditionally, why we've used these anticholinergic medications such as benztropine, I have a little joke that we saw that benztropine worked for some movement disorders, and we thought, well, we're going to use it for everything that moves. We'll just throw it at everything that moves. Well, unfortunately, that was before I think we understood a little bit more about the pathophysiology of this condition. Also, some of our colleagues may be a little reluctant to prescribe a VMAT2 inhibitor because they are afraid the patient's not going to want to take another medication. It's going to be a hassle, all of this. But what I would say is don't feel like you have to close the deal the first time you bring it up, because sometimes people don't notice the movements, or they don't think they're bothered, or they don't want to take another medicine. You're starting a conversation, and sometimes patients will come back and say, you know, now that you mentioned this and I thought about it, or I asked my family or friends, it really is more of a problem than I realized. So I think that's also important in the management plan, is to realize that you're starting a discussion and that you want to involve as many people as you can in the patient's life and in your treatment team.
If you could talk a little bit more about sort of the team that's involved in the management of patients with tardive dyskinesia. So, you know, whether that be other healthcare professionals, family members, caregivers, you know, what sort of support team do you like to get involved when you are first identifying tardive dyskinesia and continuing that care for your patient?
Sure, maybe I'll get the ball rolling on this question. It has been said, I think quite eloquently, that it takes a whole village to raise a child well. Entirely correct, though I might say it takes a small town to do tardive dyskinesia care supremely well. So I'm a prescriber, I'm a psychiatrist, I am a member of a treatment team. I think I'm an important member of this chain of treatment team members, but quite evidently, I'm not the only person, and this chain is only as strong as the weakest link. So this question really resonates with me, because in order to identify and treat tardive dyskinesia well, I can't do it by myself. I can't. So who's in the team? It is the patient, obviously. In fact, the patient is at the center of the team, always is. Shared decision-making is not just a good slogan for 2024. It is my motto. It is your motto. It is part of our DNA, or it should become part of our DNA. I think we should not exclude family members one bit. Right. In fact, one of the other research publications that we had last year was not even looking at patients, but looking at the family members who took care of individuals who are afflicted with tardive dyskinesia. And we were astonished that tardive dyskinesia per se is a source of profound stress and induction of depression, anxiety, employment difficulties, psychological difficulties in these individuals. They need support too, and they can be highly influential in assisting our patients in either rejecting a treatment or accepting a treatment.
Right.
Many of our patients have another support group. For example, they might belong to NAMI. They might belong to a church group, a men's group, a women's group. They might belong to that. If there's someone who's really important in that support system, they are welcome to. But inside the medical system, if you will, all the way from the receptionist to even the driver who often brings patients to community mental health centers, to social workers, to our LVNs, to our RNs, to our NPs, to our MDs, to our pharmacists. Yep. The entirety of the system needs to be aware of tardive dyskinesia and to alert each other. If you say something is not just a motto when you fly at an airport. It's not just a TSA saying. I think it's crucially evident. It's crucially important in both the identification and then the treatment of tardive dyskinesia. So in summary, I will say this. Tardive dyskinesia is not a solitary game. If you want to help someone with tardive dyskinesia appreciate the team is stronger than the individual, find a way to create this team. And then you will see the results of that are quite significant.
One quick thing is that it's very important also when you're involving family or caregivers to realize, as I said earlier, tardive dyskinesia does not necessarily have a sensory component. And so the patient may not be as good at monitoring the progress or the efficacy of the treatment. And you want to involve others who can give you the data, who can give you the feedback that you need to see where are you going with your progress of your treatment.
Really well said, Andy. There's not a sensory component. You're completely right. There is, however, significant pain.
Oh, 100%.
100%.
Yeah, 100%.
But the pain is confused as from arthritis, etc.
That's right.
In our survey, we found back pain to be significant. This constant movement. We found a lot of patients talk about jaw pain.
Yeah.
We found a lot of patients, particularly lower back pain, because of constant movement. Yeah. We were struck by how many blind spots Rakesh, a supposed expert in tardive dyskinesia, has. Because you know what was happening to me, Andy? I was using the lens that I was taught to use.
Exactly.
The mistake I made is the lens I should have used was the lens of the patient.
Yes.
There is no sensory component to this disorder, but it is as much a mind-body disorder as almost anything else we touch in psychiatry.
You're 100% right. The consequences of the movements can cause significant pain and disability. If you think about swallowing, speaking, grooming yourself, there's just so many, even breathing, it can affect people in so many ways. And I appreciate what you're saying about pain. I've certainly had patients think that this was a dental problem. You know, they even go to dentists, and I sometimes feel like we need to educate our dental colleagues about this. And so that's another issue where it can get missed, is the patient or the family may misattribute this to something else and may not recognize that it's connected to the medication.
I fully agree with the two of you. I also don't want us to forget the emotional pain and the grief. The grief about what I've lost in terms of physical integrity, social and emotional integrity. And that's tough. And you feel like helpless and hopeless. How can I ever get rid of this? I took the medication to rid myself of emotional pain, and now I get additional emotional pain. But there is help. And while I fully appreciate the chain that we would like to create and all of the team members we would like to have, and that's optimal care, I don't want people who don't have that, who are in solo practice, to despair. It takes three to tango, at least three. And that is the patient in the center, as Rakesh pointed out so eloquently. It's you as the provider who has ears and eyes and also a tongue to ask things and sees the tardive dyskinesia, identifies it. And the third is the treatment that can help alleviate the movements and the related emotional and physical and also existential pain that can come with tardive dyskinesia.
Christoph, I must comment on what you said because it's so true. So we did not tell patients that this was a tardive dyskinesia survey or whatever. We just identified tardive dyskinesia individuals and without biasing them, asked them how much of an impact this has on different aspects of your life. And we focused on what psychiatry focuses on, physical movements. But what we found is exactly what you just said. On a Likert scale of 1 to 5, 5 being the worst, 1 being no trouble at all, consistently, patients with tardive dyskinesia, whether it was because of mood disorder treatment or schizophrenia, were between a 3.4 and a 3.7. So think about it. They already have a psychiatric disorder. And on top of that, at around 3.5 on a Likert scale of 5, they're reporting a negative impact on their emotional health because they have tardive dyskinesia. 1 + 1 does not appear to equal 2 in these poor patients. It equals a 7.
Yeah, I was just going to say that, guys. This is the ultimate biopsychosocial condition. I was trained in the biopsychosocial model, had a profound impact on me. And this really is one of those conditions that profoundly affects people in all three of those spheres. And so again, this is more than just a cosmetic disorder. It's more than just abnormal movements. It's so much more.
All three of you were having such great discussion. I enjoyed listening to all three of you, and clearly I can tell that you all three are great colleagues, and it was a pleasure to hear and to learn from all three of you.